And I'm very careful to tell my patients, we try to do penile length preservation or restoration. We do not do penile enlargement because your anatomy cannot be altered. What you have is what you have. You cannot go beyond that. The nerves of the penis are undulating nerves, and they're meant to be that way because when you get an erection, these fibers stretch out. That means the nerves have to accommodate for that. But they cannot accommodate beyond a certain level without causing shearing forces and leading to disastrous complications, such as loss of sensation. So what's the use of having a penis if you have no sensation?
This is Doctor Talks.
Hello, everyone. Welcome once again to the Prostate Cancer Summit. I'm your host, Dr. Gio Espinoza, and it is my great pleasure to introduce to you Dr. Robert Valenzuela, who specializes in prosthetic urology, sexual dysfunction, post-prostatectomy urinary incontinence, BPH, and Peyronie's disease. He's one of the most prolific implanters of penile prostheses, artificial urinary sphincters, and male slings in the Northeast region. He's former assistant clinical professor at Squall Urological Clinic at New York Presbyterian, and he's the former director of the penile prosthesis surgery at the Icahn School of Medicine at Mount Sinai here in New York. He's also the co-director of the fellowship program at Mount Sinai as well. He's a good friend. And honestly, guys, there is no Dr. Gio Espinoza without Robert Valenzuela, because he got me started over 20 years ago in Washington Heights, New York. Right, Robert?
That's right. Washington Heights, that's the best place to be.
So I have a lot of love and affection for Dr. Valenzuela, because those were my starting roots as an unconventional physician in naturopathic medicine. So I always owe a lot to Dr. Valenzuela. Robert, thanks for being on this summit. I could not think of, we have quite a few experts in sexual dysfunction for this summit, and I just felt like it would be incomplete if I didn't speak to one of the best in this area. So thank you for being on this late day.
What a great introduction. Thank you so much. Listen, it is my pleasure. And I love working with people. And I think, my track after what I used to be pretty much an oncologist. So I used to do a lot of oncology.
I remember.
And as I transitioned to being more into sexual medicine, there's a lot that I learned along the way in terms of managing these patients and what is important. And I think the naturopathic aspect of it is extremely important. And that's where you came along. And I thought that was great to have you on board.
Yeah, that started everything for me. I remember doing prostate exams, and in this weird way, I never even expressed it to you. I said, God, I love doing this. I love this.
Man.
I used to come back home to my wife. Oh man, I had the greatest day. I felt, 15 prostates with Dr. Valenzuela, and I learned that this means that and that means the other. And so yeah, I know. That's the part of the quirkiness of maybe my own head.
Urology.
Of urology. So you do bring, actually, I have to say, and I'm glad you mentioned it, you do bring a special set of experience to the table, because unlike many trained fellows in sexual dysfunction and penile prostheses, you performed, I remember, quite a lot of prostatectomies, and you treated a lot of prostate cancer back in the day. So talk a little bit about that. How many prostate cancer surgeries that you do? There were quite a few when we worked together, so I can only imagine the whole time that you worked with prostate cancer. How many did you do, and what got you to transition to specialize primarily into sexual dysfunction and penile prostheses?
So, I trained at Beth Israel, which at that time we were associated with Montefiore and Einstein School of Medicine. And so we had an extremely good training in general urology. And so coming out of that program, I felt like, you know what, I could just hang up my shingle and go out there and practice. But what I did was I joined a group of private physicians that focused on prostate cancer and focused on oncology and stones. I was there for 2 years, and then I moved on into Washington Heights. And when I joined Dr. Contreras was a general urologist, and the experience that I brought with me in terms of taking care of the patient as a whole, not just taking care of one aspect of their treatment, but seeing the patient as a whole. And so when we begin seeing patients, my practice was built on prostatitis. So a lot of these patients presented with irritated voiding symptoms and symptoms of prostatitis. And this is what brought them in. What brought them was all these lower urinary tract symptoms. And along those lines, you wind up doing their PSA, you wind up diagnosing prostate cancer. And not only did I specialize, or I did a lot of prostate cancer, but I don't know if you remember Dr. Gollybuff and I
Sure.
in Washington Heights, we used to do between 100 to 125 radical prostates a year. So we were very busy, and that went on for about 7 or 8 years. And so at the same time, not only was I taking care of their prostate cancer, but I wanted to take care of them as a whole, take care of them post-op. I was able to take care of their incontinence, take care of their erectile dysfunction, and manage them all along. And some of these patients are still my patients today, which is great. And like you said, unlike people who have been trained specifically in sexual medicine, they miss out on that aspect. Seeing these patients pre-op, before, what they were like, what their experiences were like, what do they bring into the table, and how to help them overcome that problem, how to overcome the prostate cancer, and then what's to come afterwards. Nowadays, medicine is so compartmentalized. You have specialists for everything. So you have your guys who see the BPH, they diagnose the prostate cancer, they send them over to the oncologist. The oncologist does the radical prostate, sends them to the sexual medicine. Well, you know what? I felt like at that point I was doing everything, which was great. But then robotics came along and ruined everything for me.
That was it. That was it. It's funny because Dr. Gollybuff, I remember where he critiqued it vehemently initially. I remember him saying, well, when you have all these scars and you put them together, it's the same size. Right. And then later on he was like, whoop, if you can't beat them, join them. And he started doing robotics.
Well, Carl Olson actually asked me, and not only he didn't ask me, he told me, you got to go to California, you got to go and train, you got to come back ready to do robotic prostates. And I was like, nah, I'm too old. What happens is in private practice, you age out very quickly. You don't have the patience to spend 4 or 5 hours doing a procedure that you do in an hour and a half.
Right.
So a typical day for me on a Tuesday, I used to do 2 radical prostates, supine prostheses. I was home by 3:30. Meanwhile, these guys were doing 1 radical prostate from 7:30 in the morning to 4 o'clock in the afternoon. And so what happened? Those who are in academics can spend the time doing it. Those that are in training can spend the time doing it. I couldn't afford to do that. Mm-hmm. I had a large patient population and I had a lot of people to serve. And so, as I saw that prostate cancer, radical prostate using the robot became very safe and effective and patients were doing well, I transitioned to sending those patients out to somebody who can do a better job. Because I really believe that you got to provide the best possible care for your patients.
Right.
There were patients who come to me and say, no, I want it done by you. And I would say, and I would send them to somebody who can do it with the robot. And I think that's the right way you treat your patients. If you can't do it, send it to somebody who can do the right thing for your patients.
Yeah, and the evidence was there, or after
Absolutely.
a while, the evidence was there, and it was obvious that the robot, less blood loss, less pain, and those kinds of things.
That's right. Faster recovery,
faster
return
recovery
to work, less pain, no hospitalization, and oftentimes, there's a lot of benefits. Right? You think about a radical prostate; these patients used to stay in the hospital for 3 to 4 days. Then they had a catheter, and then oftentimes they were out of work for about 3 months, just recovering from the scar, from the incisions.
In some institutions, some places, they go home same day if they do it early enough.
Yes, they used to do it. They're doing it same day surgery.
That's right.
So, and that goes along with nephrectomies as well. So a lot of the other procedures, so it's definitely much superior.
Around that time, however, it's not like you did 100 prostatectomies a year and that's it. You did quite a lot of penile implants back then as well, maybe hundreds as well. You one of the top guys in New York. And and again, it's I think remarkable. It's almost like I spoke to recently to Dr. Easton from Memorial Sloan Kettering, and he has this wonderful experience in doing open prostatectomies, right? He did, several hundred, if not 1,000 of those before transitioning to the robot. And he finds that combination that now the current
It's amazing.
physicians they don't have that training in open. And he finds that there's value there. He says, I still have to do about 10 a year because there's a lot of, he call it a hostile abdominal environment where he still has to do an open and the new trainees don't. I find it fascinating that you have this experience, which is so useful in prostate cancer surgery, while now solely focusing on male sexual health, particularly post prostate cancer treatment. So tell us about that. So here we have a patient that, regardless of what he's trying to do after a prostatectomy, it's not happening. He's not getting it up. He's not getting an erection where he's satisfied. He and his partner are satisfied.
Yeah.
My first question is, it used to be that you had a whole protocol, and it seems as I speak to different experts, you don't need a protocol. If you are qualified for prosthesis, you get it. In other words, you don't have to, try Cialis. Try Trimix. You don't have to go through that process. So go ahead, speak on that in terms of your process before they go ahead and get an implant.
So my practice is a little bit different. It has evolved to where I am what you would consider a super specialist, right? So you have a specialist, and then there's a subspecialty within the specialty. So basically, a lot of the patients that come through my door now are ready for prosthesis. I don't have to sell it to them. I don't have to convince them of it. All I have to do is present them the data. Most urologists nowadays will practice some level of sexual medicine because it's easy. You can do testosterone replacement. You can do PDE5s. You can do injectables. All these things. So they exhaust all those resources before they ultimately send them out because they're not doing the surgery. So for me, most of these patients that come to me, not only do I look for whether they have erectile dysfunction, but I also focus on the urinary symptoms. And sometimes physicians, they don't really capture that because they're so focused on, well, how you doing? You're not getting erections, but you miss certain nuances such as, climacturia, loss of urine with orgasm. While they don't have an erection, while they may not wear a diaper, they may be still able to masturbate, and then they may leak urine at that time. So it's something I try to identify at every level with every one of my patients. The other thing is penile anatomy. We know that penile anatomy significantly changes with the duration of erectile dysfunction. So these patients that come in with erectile dysfunction, I take into account, one, what type of therapy did they have? Did they have just a radical prostate? Did they go on to do radiation therapy? Did they have hormone therapy? Because each one of those are considered insults to the penile anatomy. That leads ultimately to one, erectogenic silence. The longer your therapy, the longer your penis is going to be out of circulation. It's not going to get that nutrient that it gets, those nocturnal erections. Number two, oftentimes these patients are put on daily medication like Cialis, daily tadalafil. Well, guess what? They take it in the morning. Do you think that's going to do anything for them? No. When do these patients wind up having any kind of stimulation without, in fact, having stimulation, which means that they're having increased stimulation of the cavernosal tissues, usually at nighttime during REM sleep cycle, what we call nocturnal penile tumescence or nocturnal erections. Well, if you're giving them the medication in the morning, you're giving them a low dose, this medication is not really going to make much of a difference for them. It's been shown that it will help, but I find that giving them to them at the right time makes a bigger difference. So penile anatomy is very important. Their response to penile duplex. Not only do they have large vessel disease, venous leak.
A penile duplex is an ultrasound, right, to the penis to see that there is circulation to the penis.
Right. So even though these patients oftentimes come prepared already, they may have had a duplex at another place. I want to see it. I perform it either myself or one of my staff members, and I either walk in or have one of my members look at it and see what the anatomy is like. Is there any curvature? Is there any angulation? Is there any fibrosis? Because that's also going to help me map out the surgery. It's not that you're going to walk in blind and just put in a prosthesis on anybody. You really want to plan things out properly in order to get them the best result. So it's a step. It seems very simple. They come in, they're ready for prosthesis, you book them and you get them done. But it's not as simple as that, because the patient's expectations, they don't see their prostate cancer, they don't see their scars, but believe me, they do look at their penis. They can appreciate, or they complain loss of length, loss of girth, angulation, all these other things that come along with this type of treatment.
Well, a few of the others mentioned, and maybe you can expand on it. So we know that after, let's say, surgery, they lose about 2 centimeters of their length. A penile prosthesis does not elongate their penis, or is there an approach where you can kind of do both, kind of elongate the penis and at the same time insert the penile prosthesis?
Right. So the penile prosthesis is meant for function. It is strictly function. It is not like a breast implant that you can make it any size that you want. It does not work that way. So all of these patients, yes, on average, will lose a certain amount of length, about 2 centimeters of length, after their radical prostate or after radiation. So there are techniques, but these are highly specialized techniques and not everybody performs them. And then also certain kinds of procedures that you can do at the time of penile prosthesis to try to restore some of the length. And I'm very careful to tell my patients, we try to do penile length preservation or restoration. We do not do penile enlargement, because your anatomy cannot be altered. What you have is what you have. You cannot go beyond that, because there are limiting factors. You have the urethra that only has a certain amount of elasticity. You have the neurovascular bundles that have a certain amount of elasticity and can stretch but so much. The nerves of the penis are undulating nerves, and they're meant to be that way because when you get an erection, these fibers stretch out. That means the nerves have to accommodate for that. But they cannot accommodate beyond a certain level without causing shearing forces and leading to disastrous complications, such as loss of sensation or hypoesthesia of the penis. So what's the use of having a penis if you have no sensation? So you have to be very careful about those things. So you're right, loss of length is probably one of the biggest complaints. But I've looked at some of these patients. While I was treating them pre-op for radical prostate, I always took into account what their post-op is going to be like, and I started them on therapy immediately after their surgery. And while I was at Sinai, part of the program still is, to try to maintain function and get them back into a rehab mode as quickly as possible. And in fact, for me, if a patient has a detectable PSA, let's say you have prostate cancer, you have a radical prostate, and now you go back to your doctor and you say, oh, by the way, your PSA is still detectable. That means that you may still have disease. You may get a PET scan. The PET scan shows that there's still disease. How are we going to treat that? Going to treat it with radiation and oftentimes with androgen deprivation. Well, guess what? Those are 2 hits that are going to be on the erectile function and on the penis that can cause further shrinkage. So what I always tell my patients is, if you're going to go that route, sometimes the best thing is to get the penile prosthesis before getting the radiation, while your penis is still pliable, while you still have that elasticity, so that while you get your hormone therapy and your radiation therapy, your penis doesn't suffer for it. But we're so focused. You got to imagine, you could just imagine if you have prostate cancer, you're going to be focused on, I need to get rid of this. Sexual function is secondary, but the reality is we see what comes afterwards. So we need to be aware of these things.
That's a great point, and might be the first time I hear this, right? So this is a situation where you have a guy who had his prostate removed, and now he has a recurrence of his PSA because he has some level of relapse. He may have to undergo radiation therapy and hormone deprivation therapy or chemical castration. And you're suggesting right before you do that, get the penile implant so that it's already, it's sort of already there when you're able to function. Interesting. Guys on ADT, hormone deprivation therapy, some of them still have a desire to be sexually active. They can't because of the insults that you are teaching us about. but so they have sexual dysfunction. There's no circulation going on around the pelvic area. But some of them, so if they have an implant, they're still able to enjoy quality of life. I think that the patient, it's funny. I wonder who drives this, the physician or the patient. There are many patients. I remember working at Columbia after I worked with you, and the conversation was, well, don't think sexuality, think of what's going to cure you first. And I think that the tide has changed a little bit, where now we can talk, we can have the discussion about both. Yeah, who try to cure you, but let's talk about quality of life, and that's probably patient driven. So yes. I love the idea of, but that seems to, like you said, it's like, okay, no, the cancer. So then people, and also their physician or oncologist said, no, we need to get you going right away. Though there's a period of time where they go on ADT. I'm actually probably thinking out loud here. There's a period of time where there be of about 2 months before they go on ADT that maybe they can have their penile implant. How many patients have you seen have opted for that?
Oh, I see quite a few. So I see a lot of post-radical prostate patients. Not only do I see a lot of these patients who come in after they're having prostate, and I detect that their PSA, I test for their PSA and the PSA is slightly elevated or it's detectable. And I'm the one that oftentimes send them for radiation, or send them back to their physician and letting them know that their PSA is elevated. So, and I'm also getting more and more referrals like that. And I think the word's getting out. I think you're right. It's patient driven. The physician is sitting there. It's like, well, I'm focusing on the cancer. We need to get this taken care of. But I think the physicians are beginning to listen. They're beginning to understand the needs of our patients. And they understand that life goes on. You can treat the cancer, you can cure them, but now you want to enhance their quality of life afterwards.
Yeah.
And so, these patients who have gotten radical prostate radiation, hormone therapy, now they're undetectable, no evidence of disease. Their testosterone still is slowly coming up. At Memorial, and they looked at replacing testosterone in some of these patients after radical prostate. Mulholland, one of the big professors of sexual medicine, they said it's almost like a test of cure. If you're undetectable, you get testosterone replacement, and you can become detectable, then there's something wrong, right? Right. So yeah, we know that patients with prostate cancer can be treated with testosterone replacement in the right setting with the appropriate follow-up. That goes to show you that physicians are listening. They're paying attention to the patients and understanding that quality of life is just as important as surviving your cancer.
I love it. I see a lot of these patients, and I tell you that it's disheartening to see them. It's almost like they lost a zip to their step, and I try to pump them up, and it's like, yeah, they're not buying. It's just chemical, right? It's biochemistry at the end of the day.
Especially if the testosterone comes back. That's when it really, really hits them. That's when depression sets in. They have marital problems. They have relationship problems, not only with their spouses, but with their family in general. I think that's where the expression "angry old men" comes from.
Yeah, exactly. Exactly. And these are angry old men that are in their 50s sometimes.
Sometimes, yes.
So biochemically, they are a little bit older. A great group of people too. My heart goes out to them. And so the idea is, right. So the patient had a prostatectomy, prostate removed. They were on ADT, radiation. Now they got off ADT. Testosterone comes back. The erections are not working. So thus maybe it's and
their penis has gotten shorter.
yeah, it's Jesus. Yeah. So yeah, the right time is probably between one and the other. That would be the ideal time. That's amazing. I
have found that for these patients that they do very, very well, and they tolerate the radiation well. And after that, I mean, these guys who come to me after radiation, I wait at least 6 months after the radiation for a penile prosthesis. Because, it's just, I'd rather wait until they heal properly from that before I go ahead and put in a prosthesis. So it's a loss, a significant loss of time.
So let me ask, so they had their prostate removed, but they're still incontinent. So if they're incontinent, they're not even thinking sexual activity. They're thinking, and they can actually, if they get an erection, big if, they have a fear of leaking into their partner.
Sure.
What do we do there?
And that's where, like I said, medical history is very important. You want to determine if there's any level of incontinence, including climacteria, because that's going to affect their ability to have intercourse. And there are things that we can do for them to take care of that. So the beauty about robotic prostate cancer as opposed to open prostate cancer, we used to have about a 15% incontinence rate. We are now down to about less than 5% incontinence rate.
Wow.
And not only are we down to less than 5%, but the level of total incontinence is probably even lower than that. And that's a testament to the technique and the visibility and all these things. I mean, they've gotten so good at doing it. So these patients, it all depends on the level of incontinence. There are treatments for that. There's a male sling by Boston Scientific called the Advance.
Mm-hmm.
There's another male sling called the Virtue Male Sling. And then for those guys who are not surgical candidates, I mean, I should go back and say, first, there's medical therapy. You want to evaluate their bladder, make sure they don't have an overactive bladder, which can happen from the procedure and everything. But if you're talking in the surgical realm, you have male slings, you have artificial urinary sphincters. And for those guys with mild urinary incontinence and erectile dysfunction and climacteria, we can do a penile prosthesis and a sling at the same time. I developed a sling called the mini male sling, which is what it does is supports the urethra when they get an erection. So it tightens up the cylinders and then it lifts up the urethra to block it off to prevent leakage during sexual activity, which is key. It's very important to these patients.
That's excellent. Wow. How often things go wrong, Dr. Valenzuela, with penile prostheses, whether in the middle of the procedure, afterwards? It seems that I remember the infection rate being a bit higher than it is right now, but I'm not really on top of the literature as much as you are. So what can go wrong? And I know that infections is one of the things that can happen. And where are we with that at this point?
Well, what I always tell my patients is, look, penile prosthesis is just like any other surgery. There's always a risk of infection, bleeding, pain, malfunction. All of these things can happen in the immediate post-op period. And that's normal, just like a radical prostate. I like to compare it to crossing the street. You can cross the street, you can get hit by a car. You can look up, you look down, and you take every precaution, but somebody still comes and hits you. Same thing with penile prosthesis. We as surgeons try to take every single precaution to try to prevent it from happening, but it can still happen. Historically, penile prosthesis infection rates are about 3%, which is, not terrible considering if you don't have any function whatsoever and you can take that risk. But that's all comers. If you go and you look at specifically at implanters, high volume implanters, their infection rate, those are guys who implant more than 50 implants a year, you're looking at an infection rate of less than, let's say, 1 to 2%. If you go above that, guys who do 100 to 200 implants a year, you're looking at infection rates of less than 1%. Now, out of everybody that I know, Francois Eid, who was a well-known penile prosthesis implanter and sexual medicine surgeon, his rate of infection is about 0.45%, which is amazing. I mean, my infection rate, I tell my patients, is less than 1%. But again, it all depends on who's doing your surgery. Take, for instance, somebody who does 10 implants a year and gets one infection. He's got a 10% infection rate, right? You get a guy who has 100 implants a year. He gets one infection, you got 1%.
Yeah.
So it's all relative. Not only that, what do you bring to the table? The experience, the ability to take care of any intraoperative complications that can happen, because they can happen. You could get into the urethra, you can perforate the corpora, you can perforate the bladder. There's organs all around. These things can happen, just like with a radical prostate. You can perforate the intestines, you can perforate the bladder, you can do all kinds of havoc that can happen, but it's not that we do it on purpose. These are things that can happen, and we disclose that to our patients.
It looks like that like the satisfaction rate is pretty high after guys get a penile prosthesis. Do you know what those numbers look like? How many, are satisfied versus dissatisfied after, man, this was the worst decision I've ever made. How many of those guys out there? I mean, I can't see it,
So
but who knows?
yeah, so highly satisfied. They've actually looked at the literature in women and in men, and women it's about 85% satisfaction rate with the penile prosthesis from their
Probably it was
partners.
a lot less before the penile prosthesis.
That's right. And then for the men, it can be as high as 90%.
Wow. Okay.
So these men are very satisfied. I mean, when you're talking about highly satisfied, you're looking at about 86 to 90%. And when you're looking at satisfied for these patients, you're looking at about 95% satisfaction rates. So it's very, very high. I mean, one of the comments I get from a lot of my patients is, I wish I would have known this. I would have done this a lot sooner. And it's consistently across the board. They wish they would have done it sooner. Why? Because it frees them up. They actually did a study where they looked at men who got a penile prosthesis. There were about 20 to 30% of men who got penile prosthesis who never used it on a partner.
Hmm.
But 100% of them said they would do it again because psychologically it frees their mind from having to think, I cannot get an erection, or engaging in any kind of sexual situation due to the fear
Right.
that they can't perform, or engaging in any social event because they feel out of place, or they feel like they can't engage a partner or another person because they feel, what if it comes to that and I can't do anything about it? So it really frees up the individual significantly.
No issues with orgasms, right? They feel the same type of orgasm, and some after prostatectomies claim that they're even more
And
intense.
enhanced orgasm, yeah, that's true. And that makes total sense because you're removing the prostate and the nerves are still there, but now you get a little fibrosis and they get an intense orgasm. They may not ejaculate, but they have an intense orgasm. No, we do not disrupt any of the internal nerves of the penis. So, no, it does not affect the orgasm. And if they have premature ejaculation, they still have premature ejaculation. So, I like to compare it to a breast implant. Breast implant, a woman can get it in their teens or in their 20 years old, and yet they can have kids and they can still lactate and breastfeed. Well, guess what? The sensation, everything is still there just the same. The only difference is that you still have rigidity. Now you have rigidity. Okay. Now you can control the rigidity of the penis. Now, one of the things that I like to do to my patients is what I call corporal sparing. The penis has two chambers, and those chambers are full of spongy tissue. The teaching was that we used to use these instruments to dissect into the penis and in essence, destroy all that tissue. Well, it's been shown that if you preserve that cavernosal tissue, that tissue is still functional. You can actually do a sonogram of that tissue and see the circulation of the penis. Not only that, when patients become sexually aroused, they get a little fullness of their penis and almost feel like they're getting an erection. They may not get the rigidity that they need for intercourse,
Mm.
but that's compensated by filling the prosthesis. So that's very important. And I do that across the board with all my patients because I find that their level of satisfaction is significantly better.
Wow, this is great. All right, that's all I have for you, Dr. Valenzuela. Final
Cool.
thoughts, and where can people find you?
I think, my final thoughts on this is that, cancer, yes, I always tell my patients when you hear the diagnosis of cancer, the beauty about prostate cancer is that if you catch it on time, it's not going to kill you. It can be cured, it can be eliminated. And yes, even if it comes back after surgery, it can still be treated and you can have a very long life. And so not only do you have to think of the immediate treatment, but you also have to think of your quality of life in the future. You have to think about what's to come after that. You still want to continue having your relationship, your partner, your family, and all those things, believe it or not, can be significantly affected by by the lack of your sexuality. So I think to me, it's very important that you keep that in mind because testosterone is what drives men's libido and drives men in a lot of ways. And so you begin to notice that when you don't have that erection, it really affects you in a negative way. It's easy to find me, Valenzuela Urology. You can't get easier than that. You can just Google me, find Valenzuela Urology, and it talks about all the things that I do. So I like to keep it simple.
ValenzuelaUrology.com.
That's right.
All right, brother. Thanks so much for joining us, and thanks for enlightening us on, a very important topic, sexual health and penile prostheses after prostate cancer treatment. Thanks so much.
Well, Gio, it's a pleasure being here. Thank you for inviting me.
My pleasure.
Congratulations on your summit. I think this is a great idea.
Thank you. Thank you. I'm super excited. Hey, everyone. Thanks again for watching. I promised you right from the beginning, I'm only bringing the best to this summit, and I will continue to do so. So stay tuned. There's more to come. This is Dr. Gio Espinoza signing off, and I'll see you next time.
Thank you for tuning in to Dr. Talks. We hope today's episode has enlightened and inspired you on your path to optimal health. Each day is a new opportunity to make choices that empower your well-being. For more insights and strategies, subscribe to our podcast and visit our website, www.drtalks.com. Stay connected, stay healthy, and join us next time on Dr. Talks. Real talks from real doctors on the issues that matter to you most.